Hello, my name is Meena Kahn. I'm one of the endocrinologists at Bay West Endocrinology Associates here at the GBMC campus. And today I would like to continue the discussion of outpatient type 2 diabetes management. And specifically in this module, I would like to discuss the treatment of a patient who has failed monotherapy with metformin. I would like to return to our patient from the first module. As you recall, he was a 53-year-old man, and he is now returning for a follow-up visit. It's been 6 months since his initial visit, as he missed his follow-up 3-month appointment. He did increase his metformin to 1 gram twice a day, as you advised, and he's tolerating it well without nausea or diarrhea. Despite this, his A1C today is elevated at 9%, and he's gained 10 pounds. He has not been checking his blood sugars at home. He is overweight. He still has long-standing hypertension and hyperlipidemia, and his medications, as you recall, in addition to metformin, he's taking lisinopril and simvastatin. On exam, is essentially unchanged from his initial visit. However, he has gained 10 pounds, so his weight's increased, and his BMI has therefore increased to 35.1. Otherwise, his exam is unremarkable. You decide to repeat some lab work, including kidney function, which comes back normal with a creatinine of 0.9, and a urine microalbumin creatinine ratio, which is normal, less than 30 at 20. The next step in treatment, as seen by the American Diabetes Association guideline, shows that he has failed monotherapy with metformin and now requires either a 2-drug combination or a 3-drug combination. The options include sulfonylureas, TZDs, DPP4 inhibitors, GLP1 receptor agonists, or insulin, which I will not be discussing on this module as it will be discussed by my colleague in the next module. The American Association of Clinical Endocrinology has an algorithm depending on the baseline A1C of the patient. This was shown in the first module. We can see that our patient falls into the middle pathway in that his A1C is 9% and therefore between 7.6 and 9%. So he should be able to achieve A1C goal by adding an additional anti-diabetic agent, which is not insulin. If your patient has an A1C greater than 9%, and especially if that patient is symptomatic, he or she will likely require insulin in order to achieve glycemic control. But again, this will be discussed further in the next module. When considering which agent to add second, most of the agents bring down the hemoglobin A1C by approximately 1%. DPP4 inhibitors, which include Januvia, Onglyza, and Tradjenta, decrease the A1C by approximately 0.6 to 0.8%. Sulfonylureas, which as you know include amylyl, glipizide, and glyburide, will decrease the A1C to 1 to 2%. TZDs, which currently include Actos, will decrease it to 1 to 1.5%, and studies have shown that GLP1 agonists, including Byetta and Victoza, will decrease the A1C to 1%. However, I have noticed in my practice that I do see a greater A1C reduction with GLP1 agonists, and one should remember that the initial studies done with these medications included patients whose A1Cs were in the 8% range. In considering which medication to add next, one should consider the patient's comorbidities, if any. If the patient has coronary artery disease, metformin has been shown to be beneficial in the UKPDS trial. One should avoid hypoglycemia, which was clearly outlined by the ACCORD trial. There's a special concern with glyburide, as it may cause ischemic preconditioning. There does not seem to be a class effect with TZDs and coronary artery disease, and thus far pioglitazone has been seen to be okay to be used per the studies. The next thing to consider is if a patient has congestive heart failure. One should avoid metformin in class 3 and 4 heart failure and avoid TZDs as well. In the setting of renal disease, there's an increased risk of hypoglycemia with sulfonylureas, especially glyburide, as the metabolite is active and therefore there's an increased risk of hypoglycemia with glyburide. Metformin should be stopped if the creatinine is greater than 1.5 in men and 1.4 in women, and DPP4 inhibitors often need to be dose adjusted in the setting of renal disease except Tradjenta, which does not. In the setting of liver disease, insulin is the best option, especially if the patient is cirrhotic. However, there is some evidence with studies that show that pioglitazone may reverse fibrosis seen in non-alcoholic steatohepatitis. And spend a little bit of time discussing the GLP1 physiology, as a relatively newer classes of agents for glycemic control involve this pathway. GLP1 is a hormone which is naturally secreted by the intestinal cells and is important for glucose homeostasis. Exenatide was the first medication FDA approved, which is a GLP1 agonist, and Victoza and Byetta both work by the same mechanism. They enhance glucose-dependent insulin secretion. They also suppress glucagon secretion, which in type 2 diabetes is one of the causes of fasting hyperglycemia. They induce satiety and thereby help with weight loss, but there is also an independent mechanism of weight loss as well. They do slow gastric emptying, and therefore in patients who have gastroparesis, this class of medication should be avoided. In animal studies, there has been evidence that it may actually increase beta cell mass. And for type 2 diabetics, this is exciting because it may actually slow down the progression of the disease. This is a slide illustrating the glucose-dependent insulin secretion. So in the top box, you can see that as glucose is infused and serum glucose levels increase, in patients who are treated with Byetta, which is the dark blue bar, which is a bit difficult to see as compared to the light blue bar, but if you look closely, you can see that insulin secretion increased as glucose levels increased. And as the glucose level came down, insulin secretion also came down and was then turned off when the glucose level was normal. Therefore, the risk of hypoglycemia in this class of medications is essentially zero. The current GLP agonists, which are FDA approved, include Byetta, which is a twice-a-day subcutaneous dosing. It comes in two different pens, a 5 microgram pen and a 10 microgram pen. Each pen lasts for 1 month. So if one starts with a 5 microgram pen and advises patients to use it twice a day, after 1 month, if there's no nausea or diarrhea, the dose can be increased to 10 micrograms. The pen needles must accompany a prescription for pen needles as well. The next medication which is approved on the market is Victoza. Victoza is a nicer medication for the patient because it involves only once-a-day dosing. All 3 doses come in 1 pen. I generally start with the lowest dose at 0.6 milligrams and have the patient titrate up the dose weekly as long as the patient tolerates it without any side effects. If at any point the patient has side effects of nausea or vomiting, I advise the patient to stay at the current dose until hopefully those symptoms resolve. Obviously, if the symptoms do not resolve, then the medication will need to be discontinued. Studies have shown that the 1.8 milligram dose does not provide an increased glycemic benefit as compared with a 1.2 milligram dose, and that dose is beneficial in weight loss alone. The last medication which has been FDA approved is Bydureon, which is exenatide extended. It is a once-a-week dosing, and it comes in a syringe pack which must be reconstituted. The next class of medications are DPP4 inhibitors. The enzyme which breaks down GLP1 is DPP. By inhibiting the enzyme, endogenous levels of GLP1 are increased. The medications in this category include Januvia, which comes in 3 doses, which does need to be renally dosed if the patient has renal disease, Onglyza, which also needs to be renally dosed in the setting of renal disease, and the third one is Tradjenta, which does not need to be renally dosed and only comes in 1 dose of 5 milligrams. The A1C reduction one can expect again is 0.5 to 1%. This class of medication is weight neutral and does not induce weight loss. However, it also does not cause hypoglycemia and therefore is a great option in our older patients. One must also consider the goal of treatment aside from euglycemia. Some things to consider are whether one wants to choose a drug which is either weight neutral or may induce weight loss, one that will avoid hypoglycemia, or if cost is an issue. If we go back to the American Diabetes Association guidelines, they have broken down the algorithm based on the additional goal required in treating the patient. If the additional goal is weight neutral or weight loss medication, the options include DPP4 inhibitors or GLP1 receptor agonists. If one wants to avoid hypoglycemia, then the choices include either a TZD, DPP4 inhibitor, or a GLP1 receptor agonist. And if one wants to minimize the cost for the patient, the best option is still sulfonylureas, which are quite effective in achieving glycemic control and still cost-effective. Another option would be basal insulin, which again will be discussed in the next module. At this time, I would like to return to our patient. As you recall, he's a 53-year-old man who returns to you with an A1C of 9%. In addition to metformin, I opted to start him on Victoza with a starting dose of 0.6 milligrams daily. The reason for this choice in this patient is because he had gained 10 pounds since his last visit, and in addition to glycemic control, I am also hoping for some weight loss as well. I advised him to titrate up the medication to 1.8 milligrams over the course of the next 3 weeks, as long as he tolerated it without any side effects of nausea or vomiting. He was also advised to start a formal diet and exercise 2 to 3 times a week for at least 30 minutes at a time. I've asked him to come back for a follow-up appointment in 6 weeks in order for close follow-up. I have found in patients with this regimen who also pursue lifestyle changes with diet exercise for a goal of weight loss is effective 60% of the time. However, without pursuing lifestyle changes, diabetes typically does progress, requiring insulin over time, and this will be discussed in detail in the next module. Thank you for your time today. Again, my name is Meena Kahn, one of the endocrinologists at Bay West Endocrinology Associates on the GBMC campus. If you have any questions, please give me a call at my office or feel free to email me. Thank you.